Now that we have all three distinguished speakers with us, welcome everybody. Tonight we wanted to keep it small. This seminar really is about you guys having the opportunity to interact. What we have collectively is, I won't say 100 years experience up here, but at least, because I said it in passing and they took umbrage to it, but at least 90 years of significant experience. Well, if we divide it by 3, that's only 30 each, guys.
I'll take that deal. I'll take it.
This is a really unique opportunity for us. This is your capstone of your capstone. And I will formally introduce our 3 distinguished panelists more. And just to read their bios will probably take most of the course, because they have had really exemplary careers. But I would like to, before I introduce them, they had asked to have an opportunity to find out who you are. So if we can just go around the table and just do a short sort of who you are and why you're here and what you plan on doing, that would be a good way to start this dialogue and presentation. So how about you, Jacqueline? Do you want to start?
Hi, my name is Jacqueline Patterson. I do healthcare administration and operations at a community health center, and I also am a naturopathic physician. And I have a year and a half left for my MBA program.
Hi, my name is Christina Borowski. I am actually a medical lab science major. I am not a MD major. This is my last semester here that I'm finishing, but I would like to get into laboratory management.
Hi, I'm Adam Dworkin. I'm the practice administrator for the Griffin Faculty Practice Physician Group, and I already have my JD MBA, and I'm working on some healthcare compliance.
I'm Maria Passarelli. I'm a practicing urologist in the community, and I'm looking for possibly changing my career in the next few years.
I'm Sarah Brockett. I'm a financial analyst at the Yale Health Plan at Yale University. I have quite a few years left for my MBA because I take part-time classes, but I hope to finish that soon.
Excuse me, I stutter, so bear with me. Peter Forte. It's my first year in the program, and I want to become the administrator of a nursing home, and I'm interning right now at one in Bloomfield, and it's pretty cool.
And you know, Peter's an example of passion and tenacity for this field, because we usually only take professionally experienced people into it, and he knocked on my door, and he's really doing a terrific job. So, you know, he is one of our future leaders in that. And Dale, can we just go back to you?
I'm Dale Jasinski. I'm the chair of the management department, and I'm very proud that we have people like Angela Mattie in our department to exemplify, you know, all the, we talk about the 3 legs of the stool of scholarship, teaching, and service, and what she's doing tonight is probably the greatest example of how all 3 can come together. So proud to be here tonight.
Well, it's a mutual admiration society, because I always say Dale is, in academia you have no bosses and you have 20 bosses. So Dale heads the management department and oversees 16 college professors, which is like herding cats times 2. So, you know, and he does a fabulous job. So I thank you for being here tonight, Dale. Thank you.
I'm Kristen Vernon. I'm an MRI technologist at Yale New Haven Hospital. I also work for DM at Norwalk Radiology, which is an outpatient facility. I'm also adjunct faculty in diagnostic imaging at Quinnipiac. And I am right now still in the MHS program, but I'm switching over to the MBA program. And I'm still kind of a kid who doesn't know what they want to be when they grow up, but I'll figure it out.
I'm David Ficini. I work at Yale New Haven Hospital in radiology and compliance. And after this semester, I have 3 classes left for my MBA.
My name is Chris Reams. I work at a smaller accounting firm up in Cheshire. Finished the CPA exam last year. I'm working on finishing up the requirements for the experience, and I have 3 classes left for my MBA.
I'm David Prasuti. I'm also an accountant. I work for KPMG, and I hope to someday get into the finance side of healthcare.
Kristen Gabriel. Just graduated from Quinnipiac last year in management gerontology. I'm getting my MBA in healthcare management, and then done this May. Hope to work in long-term care when I'm out.
I'm Austin Potter. This is my first semester at Quinnipiac, so I have another year to go working towards my MBA. I currently intern at Gaylord Hospital with Mr. Cullen, so happy to have him here.
And we're very happy, Jim. I'm going to say this when I formally introduce you, that you have played such a leadership role and really become a friend of the program and really been a wonderful mentor to Austin. And Jim has also volunteered to continue that role, so we're going to talk about how we can formalize some matching there.
Hello, my name is Kabir Nain. I'm an administrator for a small nursing home in Bloomfield, Connecticut, and have been for the past 4 years. Seabury, it's part of an active life care community.
I'm Justin. I'm a first year in the program. I work part-time at a hospital back home. I hope to get into pharma after I graduate.
Where's back home?
Mass.
Hi, my name is Ian Livingstone. I'm in the 5-year MBA Healthcare Management program. I'll be graduating in May, and I currently intern at the VA Medical Center in Newington in the Fee Basis Department.
I'm Danielle. I work at Quinnipiac as an athletic trainer for the rugby team here, and I want to get into like a sports medicine clinic.
I'm Colin Wilkinson in the 5-year MBA Healthcare program, and this summer I'll be working at the Leahy Clinic in Burlington, Massachusetts, in their operating room doing supply chain management.
Great. Well, thank you. And did we miss somebody? Who did we miss? Who's?
I'm Gina Frank.
Oh,
the Associate Dean of Students.
Oh, well, I'm going to formally, we're going to formally, because we found Gina. Well, actually, Austin found Gina. So, you know.
We have one over here.
Yeah,
Who do we miss?
Oh,
yes, go ahead, Emily.
Hi, my name is Emily Austin. I work right now as a CNA at Butler Glen, Middletown. I have one more semester to go, and I'll graduate with the corporate compliance certificate and management degree.
Great. Another good student. All right, so welcome to an evening with healthcare executives, and we will talk about what's facing the industry. And because this is your last class here, you'll have a chance to ask them what you should be doing, and I hope there'll be a dialogue. Each of our speakers will do about 15 minutes of remarks, and then we'll open it up to the floor. But before I do that, I need to thank Gina. Please stand up, because Gina we are going to make her an honorary Master's in Business Administration and Healthcare Management graduate, because she just has been unbelievable in terms of support. And also Austin, who is actually, look at Austin, because he's a future CEO of a healthcare place. Austin really has, I told him I'll never throw in a party unless he helps. So he's actually going to come to my house for my next cocktail party, right? And Gina too. So both of you, and can you give them a hand, because they really. All right. So just a few quick introductory remarks. You guys all know every time we do this, we have to look it up because it changes daily. How much we spend on spending and gross domestic product in healthcare is about 17.3%. But we have a pretty screwed up healthcare system. This is some recent information from the Common Fund Survey or Commonwealth Fund Survey that said the majority of Americans say we need some fundamental change. All right, everything is screwed up between access, medical errors is another issue, and waste and inefficiency in the system. Part of what we're going to hear, and we're very fortunate to have somebody who has some significant Hill experience, is what was Congress thinking when they put together this 2,000-page document that became the healthcare reform bill. Within that document, there's 1,000 areas that say, and you correct me if I'm wrong, the secretary shall. So in other words, somebody's got to figure out how to do this stuff. And we'll learn a little bit about how things really get done up there. And then these guys have to implement it, so they'll talk about what they're left with. We have a whole new vocabulary as a result of healthcare reform, accountable care organizations, comparative effective research, more additions to alphabet soup. So we have 3 experts today who are going to talk about how we ended up where we are, where we're going in the future. Our first is William Hoagland, who is currently the Vice President for Public Policy for CIGNA. Now, unfortunately for him, that school down the street, what do they call it, Yale? Had a health policy seminar, which I had the privilege of attending with a few of my students, and I saw you speak, and I thought you did a terrific job, and your insight or knowledge about the Hill is just absolutely invaluable. And I sent an email because I thought he'd be like every other man in my life and say no, and he turned around and said yes. So he actually came up today from DC on a train to see you guys.
Shows you how much I wanted to get out of Washington. That's what
But I think that speaks volumes for the role that you guys are going to play in the healthcare delivery system, and also volumes for you to make that effort to come up here. So he comes from 30-plus years experience on the Hill, and he'll be very modest, but he was quite the big shot on the Hill. And I said I recognize him. Well, I recognize him because he was essentially well, you weren't behind the scenes. You were running Senator Frist's office in healthcare for a number of years, and I never forget a face. At my age, I can't remember much of anything else. And I knew that I had seen him directing things and really had your imprint on healthcare policy is there and continues to be there. And you have made some significant contributions to the field. And CIGNA is very lucky to have you as Vice President of Public Policy where you currently are. You have budget experience, just an unbelievable depth.
That's enough, Angela.
No, but I really, it also speaks to the fact that, Quinnipiac can actually get somebody here of your caliber, so I look forward to your, I'm making it up as I go. Okay, we'll go on to Dave now.
You know what they say, though, when you're 3 miles out of town, you're an expert.
Right. Now, Dave Fusco, who is currently Anthem Blue Cross and Blue Shield of Connecticut's president. I used to see Dave in the hallways. We used to talk Italian to one another. The hands used to move at Anthem.
You don't have to tell any stories about me. That's like a different twist than Williams does.
But Dave really has made a difference. He was young and energetic when he started as president of Anthem. You and I are about the same age, so I could say that.
You didn't tell me this was a roast.
I might have a few stories too, so be careful.
I know you do, Dave. But you have been with Anthems for a number of years.
26.
Is it 26 years? Wow.
You're too young.
But David's really worked his way up. He has the combination that a leader needs. Number one, he's very bright, and number two, he's very high on the emotional intelligence level. People like Dave. He understands people. He understands issues, and he's really been able to lead in a very difficult time because you guys are transitioning out. So not only is he a leader in terms of health policy and implementing health policy in Connecticut, but he's also been able to transition and work with his staff in a very difficult time for a lot of people. So, and Dave, you have become a friend of the program because Roz Benchy-Treat, who does a wonderful job as an adjunct for us, hooked you in, told me what a fabulous job you did. So I very much appreciate your time and energy, and I know in a busy day you were putting together materials for
It was a long journey
Dave.
over here, I have to say.
So it's much appreciated, Dave. And then last but certainly not least is Jim Cullen. And Jim, who was my finance professor at that place down the street. You don't remember Jim, though. I had.
I don't remember much anymore.
I understand that, Jim. He was the CEO of St. Raphael's at the time, and he would sketch out time to come over and teach a finance class. And he did a wonderful job at St. Raphael's Hospital, balancing both the margin and the mission. And I know it well because, Jim, when you were CEO, my mother was sick at the time, and we were in and out, and we had everybody from the Hospital Association calling your office and moving her through the ED. So he did take a short stint outside the state and came back to run and Gaylord Rehab Hospital, which is another fabulous place. Absolutely terrific place. you're one of two places that have vent beds, correct?
In the state, yes.
Yes. So it really is an in-between place between acute care and the home, and Jim has done an unbelievable job. And in addition to that, we are grateful. Jim is now also a friend of the program because he has mentored and done a wonderful job with Austin. Really spent a lot of time, energy, and effort, and for that we're grateful for everything that you've given back.
And I gotta give Ed O'Connor a plug, because he's on our board.
Right, Ed O'Connor, which he's out of town. We did extend the invitation to Ed, and Ed sends his regrets. So can we please give these three gentlemen a hand for being here? And with that, we are going to begin the presentation, and I could either turn the computer over to you, or I could be Vanna White, either way.
And there's a way we can make this
Bigger.
by going to this little
Yeah.
icon.
Yeah. My students are laughing because, under my name in the
That's it.
directory's techno retard, so.
Well, thank you very much, and it's, as I say, it's a pleasure to be out of Washington. The Congress is on recess this week and next week, and so there's an opportunity, and I as I was telling Angela, I get a lot more done on the train than I do in my office, so I thought it was a good opportunity. And she's heard this story, so let me begin. These are the real experts. I'm just an old political hack, and I've only been with CIGNA now for about 3 years, coming off the Hill, as she said, a long time on the Hill. I've had to learn a lot about this industry, and I did have a little bit of background in the area of the federal budget, and as we all know, the issues that are being debated today are inextricably linked between health care and the federal budget and then out into the private sector. So this has been a real experience for me and an enjoyable experience, but I just am amazed, and I listen to all of you in terms of what you're doing. My heart goes out to all of you. I keep up what you're doing, stick with it. It is a wonderful opportunities that you're going to have going forward, as tough as it sounds right now in terms of what you're hearing. My respect goes out to all of you. She's heard this, Angela's heard, your professor's heard this story, so I apologize, but I do think it's worth repeating a little bit. It was Christmas Eve morning, December the 24th, 2009, and the United States Senate had just passed the health care reform bill with 60 votes. We don't get into that if you want to get into what's called a filibuster, but 60 votes. And a young page ran off of the floor and over to Reagan National Airport to grab a plane to go home for the holidays. And he got up to the check-in counter, and the clerk looked down at him and said, and this is a true story, the Senate historian told it to me a couple of months ago. And the clerk looked down and said, "I'm sorry, son, your luggage is 10 pounds or 8 pounds overweight, 6 pounds overweight, I guess it was." And he said, he was very dejected. We don't pay our Senate pages very much in the United States Senate. They are young high school students. And he looked very dejected. And the clerk looked down at him and said, "Well, isn't there something, son, in your backpack that you could take out and simply carry onto the plane?" And he reached into his backpack and pulled out this. This is when a Senate or a House votes on a bill, on every individual senator's desk is the bill they're voting on. And he grabbed this as a souvenir as he went off some senator's desk and ran over, and he took it out of his luggage, and it does weigh 8.6 pounds. He carried on to the plane, did not have to be charged the fee for going on it. Part of the issue of this particular legislation, that these gentlemen and my company are having so many issues in terms of just implementing this, has to do with the fact that, as you will recall, this passed the United States Senate, and it went to the House of Representatives, but there was a special election up here in Massachusetts that changed the makeup of the United States Senate so that there were not 60 votes but 59 votes. And as a consequence, in the United States House of Representatives, they had no choice but to, if they wanted to get this legislation to the president for his signature, I always think of this as Gary Coleman's look-alike here. In order to, I'm surprised you guys even remember Gary Coleman, some of us. In order to get this to the president for his signature, you could not change one word, one period, one comma in this particular piece of legislation. Why? Because if you made any changes in this, it would have gone back to the United States Senate, where there were not 60 votes now because of the special election up here. So we used to have an old saying as a staffer on the Hill, we will fix it in conference. We will fix it in conference. There was never a conference on this bill. This is what he is signing on March the 23rd, 2010. Now, we can go a little bit further. There was a technical issue that came along afterwards. It has to do with something called a budget reconciliation bill that could make some minor modifications, but this is what was signed. So this is where we are today. This is the legislation, and I thought it was 865 places. Now that I'm learned the technology that you guys are so adept at with word search, if you look for the 3 words, your professor is correct. I think it's close to 860 times that the secretary shall appears in this, meaning that, again, had we gone to conference, a number of these issues, dates, issues, inconsistencies would have been worked out, but were not worked out. In the interest of time, I just want to run real quickly because I want to hear the experts, the real experts here in terms of the policies and implementation. But interestingly enough, if you go back and look at the time this was signed into law, shortly afterwards, in terms of the favorable, unfavorable rating out there, and where we are today, in fact, this has just been updated for March, this is a very divisive piece of legislation. And there was a time when I was on the Hill, we passed legislation, we implemented it, we went on to something else. This thing just never ends. It is continuous. And it has been the thing that's been occupying even this Congress, the 112th Congress, from the day one they were sworn in, with H.R. number 2 basically being the repeal of this particular piece of legislation. I thought it was interesting that the first thing that when the new Congress came into existence, this Congress came into existence with a new House of Representatives, much more conservative representatives, that the first thing they did was to read the Constitution on the floor of the United States Senate. And what I find interesting is that they went right through the Constitution, Article 1, the legislative branch, Article 2, the executive, Article 3, the judicial branch, and of course, Amendment number 10 to the Constitution dealing with the states. For those of us policy wonks that have been in this business for a long time, it doesn't get any better than this. Every branch of government plus states is involved today in this particular piece of legislation. It is massive. And it's flowing down to you in terms of implementation, obviously, and carrying out the goals. The legislative branch, don't spend a lot of time on it, but basically what we have here is that in the United States Senate we have 53 Democrats, 2 independents, and 47 Republicans. The magic number, as a young staffer, I was told, it's not 51, it's not the majority, it's 60. You need 60 to shut off the great deliberative body called the United States Senate so that they can go and do work. So you can't really pass anything right now if you're intent on stopping legislation in the United States Senate. But with a majority in the House of Representatives, the first thing they did, one of the first things they did, of course, was to pass legislation called H.R. 2, repealing the job-killing health care law. This one right here. And they passed it, but of course it did not pass in the United States Senate, so that's off the mark. I've done a couple of checkoffs here. I'm glad you got the checkoffs here. That's great. Thought I put those in yesterday. State of the Union address, President's budget. One of the things that you're hearing so much about today, and is coming full force, is the fact that we have spent almost all of our time up until last week when they went out on recess on just funding the government for this fiscal year. Our federal fiscal year begins on October the 1st and ends on the end of September. We have just finally finished that last week with a grand total of $38 billion in savings. That is a minor issue as to what is coming up here very shortly, which has to do with what we call the statutory debt limit, raising the statutory. Now, I'm going to tell you why this impacts upon health care and where you're going in just a minute here. Last week also, Mr. Ryan, young chairman in the House Budget Committee, passed what we call a budget resolution that's a blueprint for how he thinks policy should go forward. And that policy going forward is a major, major change in the structure of the Medicare program, a major piece of legislation. We'll come back to that. Beyond that, we have issues going on, which, so those of you doctors will know this well, is that we have something called the sustained growth rate, the SGR rate, which expires at the end of this year. And if we do not fix that, we're talking about something in the neighborhood of a 29-30% across the board reduction in reimbursements to doctors for Medicare. That has to be fixed before the end of the year, and it will cost to do that. There was an issue which we did do, which was a simple little fix on the only fix that has been done in this legislation, which was done on a bipartisan basis, had to do with some reporting requirements, having to do with businesses having to report their expenditures in excess of $600. It was a very controversial issue, but it was to save money, it was to raise revenues, and it was repealed, and the President signed that last week. Beyond that, we have lots of other issues that are out there going on, but what I have to tell you is, and I told Angela this when we were in jail, the issue here is that with that particular, as controversial as this particular piece of legislation is, that when I go to the Hill with an issue that Anthem Blue, we work with Anthem Blue Cross, we work with, that there are issues in here that need to be fixed, there are dates that are not right, there are things that just don't make any sense. The biggest response I get from old friends, particularly in the House of Representatives, is, Bill, we're not interested in fixing this. We don't want to fix this. We want it to fail. That's the politics that we're dealing with. There are things that definitely should be fixed in here. By the way, I should say, probably the advertisement I should have made at the outset, CIGNA supported health care reform. We supported the issues of expanding access to those who do not have health care. We supported the issues that the President had in improving the quality of health care that's delivered for the dollar that's out there. Most importantly, we obviously focused on the issue of reducing the cost of health care that was shown at the outset in terms of the amount of expenditures. I think they were successful on one of those. I don't think they've been quite, we don't know about number two in terms of quality. And number three, I think we're a long way from controlling costs with this particular piece of legislation. In fact, some would argue it adds to the cost of legislation. In the interest of time, I'm just going to jump over a couple of quick things here. Why did I say debt limit? You are hearing so much about the statutory debt limit. Just a quick little refresher, give you a little finance course here in federal budgeting. There is a law on the books. The last time it was passed, statute 124, statute number 8, February 12, 2010. There's a law on the federal books that says at no time today can the total amount of federal borrowing outstanding exceed $14.3 trillion. What is that number? That's going back to the beginning of this republic, from the beginning of this country to today. That's the accumulation minus surpluses of debt that we have accumulated. We are today, on April the 14th, we're at 14,271. We're $20 billion. That's basically what we spend in one day. Now, taxpayers, you've paid your taxes, I guess, on Monday. Receipts coming in. We don't know when we're going to hit this $14.3 trillion, but it's going to come. It's going to come sometime between May the 15th and the end of June. When we hit that level, we have already been told that there are those in the House of Representatives who say they're not going to vote to raise. The only way you can avoid this, of going above this, you have to pass a law to raise this number. When they come next, after May 5th, and when they come back after this recess, they will have to pass a law to raise that. And there are those members who are saying we are not voting to raise the statutory debt limit unless you change now, find more savings in the healthcare area and in the federal budget. I would have accepted, I worked for, cards on the table, I worked for Republicans in my career. I would have accepted last week 2 days, 3 days of government shutdown. That doesn't scare me that much. But what scares the bejesus out of me as an old budgeteer is if we default. The country has never defaulted on our debt. Why is that important? Because about 50% of our debt is owned by foreign investors, beginning with China and Japan. As a consequence, when we get to the point of having to change this number, there will be proposals to make further. I wouldn't be surprised that there will not be another effort made to repeal this legislation completely, which won't go anywhere, but there will be changes recommended to make further changes to the Medicare program and the Medicaid program, and through a number of particular procedures coming up. So this thing is not ending. It's not going away. And just to make sure you, as I look around the room, it's really you guys. As old fogies, I'm a child of the 60s. I got mine. This hits you. This hits you more than anybody else. And that is that today we are running a deficit in the neighborhood of a $1.4 trillion. And as a percentage, and just think about this, as a percentage of our total economy, we're at about 70, our debt to GDP is about 70%. I remind you that Greece was at 80%, and we are continuing to grow that up. That's why the President's talking about it, that's why this is an issue, and that's why healthcare reform in terms of reforms coming back on the cost side are going to come back at us in a big way. So how do we control cost of healthcare going forward? Just to make sure, one last point here from a budget perspective. The whole debate about government shutdown and the $38 billion, guys, was peanuts. It was nothing. What they were arguing about was 13% of the federal budget. 13%, the non-defense group. What the real issue is in terms of if you're trying to control our debt and deficits and those debts is, you know this, Social Security, Medicare, and Medicaid. That's why Mr. Ryan has focused so hard on Medicare and Medicaid. That's where the real issues are. And by net interest on the public debt, that's just paying that, and the finance experts here, that's just paying the annual interest payment on that debt that we've accumulated. 70% of our budget. And defense is 16%, and that is in the Constitution that we're supposed to protect this country. So no question in my mind in terms of the pressure that's going to continue to be placed back on all of us, administrators, people out, is these issues up here, these programs of Medicare and Medicaid going forward. I don't want to just point out, this is the dilemma. This is the implementation. You can't read this, there's no reason to. This is meant to scare you. All of the activity that's required to implement this thing going forward. Right now, primarily where we are is in 2010, 2013, just a number of small issues that we're dealing with in terms of issues going forward. I'll truncate my remarks here to leave time for, as I say, the real experts on how we implement this. But I want to point out two things here, at least one that really I've seemed to be spending almost all of my time with these days, and that is MLR, medical loss ratio. This is, the law says here that if you're an individual or a small group insurer, that you have to maintain a medical loss ratio of 80%, meaning take the total premiums you take in and take the amount, total expenditures in and try to figure out how much. Basically, it's saying that 80% of all the premiums that come in have to be spent on health care, and 20% can be available for, quote, administrative cost and operational issues. And there's a real question as to what is in that 20%. The other issue is that's for small individual and small group. For large group markets, and by the way, CIGNA is primarily, and I get myself in trouble when I tell my CEO this, and please don't tell him I said this, is that we are, CIGNA really is a data processing firm, because well over 80% of our business is large group self-insured. They're the ones who hold the risk. We simply manage the data. So it's these guys that are the ones that have to deal with, are holding the risk. We just manage the contract for those large group markets out there. But anyway, this medical loss ratio is something that's been established, kicks in this year. In fact, the first reports will come in on April the 1st and have come in on April 1st. But the real aspect is if you don't meet those targets, then we have to reimburse back out to it says the individual, that which if we don't hit that target. And it's an administrative nightmare that we're having to go through and figuring out how to handle that particular issue. That's a major issue. The other ones, and
We'll find out that, too.
I don't want to cut them off, okay. There's a whole series of things that are underway this year. As you can see down, closing the Medicare drug coverage Part D, Medicare Advantage, we're definitely reducing the Medicare Advantage payments starting this year for those programs. Let me just say, it's a real subtle point here, but I guess I'm still a budgeteer at heart. All the criticism that Mr. Ryan took, and I'm not defending him or not on his budget, they proposed to repeal this particular piece of legislation at the beginning of the year. You should know that he did not repeal, he did not assume, in terms of the budget that was adopted in the House last week, that those savings from changing Medicare Advantage that was in this bill go away. In other words, he kept those things that save money and then tried to reduce those things that added to the cost going forward. And interesting, but just pointing up how important it is that the focus of all this has come around the budget and reducing that federal exposure on the federal deficit side. The other issues that I wanted to head, I'm not going to talk too much about the Medicare Accountable Care Organizations, the ACOs. The concept, I think, is good. Those of you who know much more about this than I think the concept of some way of coordinated care and rewarding those providers of the doctors, the hospitals, where you do reduce the cost but improve the quality, and rewarding you for that. I think that's a good concept. This is supposed to save about $500. This is only in the Medicare program. Personally, I've seen a lot of these experiments over the years. I'm still not sure it will transpire, but this is underway right now. At the time I put this together, those regulations were imminent. Now they're out and they are being implemented for next year. But the one that is going to become so big with insurance companies as we go forward, besides the medical loss ratio, is the essential benefits. What is defined as an essential benefit, and how and what goes into that definition? Because all of this is going to translate into the requirements that the benefits that are provided out there have to meet some required level of defined as essential. And not meeting essential benefits then, of course, then translates into being fined. But more importantly, for those of us who work in the private sector dealing with the employer-provided health insurance, which makes up about 60% of all the health insurance out there, is that the requirement that there be that the employers provide health insurance or that they be fined, well, it depends upon what we define as essential benefit going forward. That is very much in the air right now, being worked on, and should come out at the end of the year. In terms of this grid here is simply pointing out that if you are an employer beginning in 2014 and you do not provide health insurance benefits, and any one of your individuals goes over and qualifies for benefits on the exchanges, which I'll get to, which is the other thing that's coming along right now, then there's a major penalties that are levied upon the employers. The whole issue here then revolves about, I don't know about this next issue, and that is whether or not this is constitutional or not. And boy, have we, as I said, we've got the legislative branch, we've got the executive branch, and we've got the judicial branch. And right now, we've got 5 cases out there that deal with this particular piece of legislation. 2 of them, the Northern District of Florida has ruled, Judge Vincent has ruled that that provision in here that says individuals have to have insurance, the individual mandate, is unconstitutional. More importantly, back to my Hill experience, on the Hill I worked on legislation where there was questions of constitutionality, but we had a conference on, and we usually would work it out, and we would put into this legislation what we call, and I'm not a lawyer, I'm certainly not a constitutional lawyer, but we would put in what we call a severability clause. Because of the way this went together, as I explained to you, with no conference, there is no severability clause, meaning that what the judge in Florida has said is that one little provision in here, if he rules, if that is unconstitutional, the whole thing falls. We have a judge in my adopted home state across the river in Virginia who has also ruled that the individual mandate's unconstitutional. We have 3 judges that have ruled otherwise. By the way, you'll start to know I never thought this was true in the judicial branch. Politics plays a hand in even the judicial branch. And so these are Republican judges and these are Democratic judges that are ruling this. Those now go to what we call the appeals court and whether they'll be appealed. We are having the judge in the case that this is unconstitutional is going before the 11th District Court of Appeals come June I guess it's June the 6th shortly, to hear whether or not this should be expedited to the Supreme Court right now, or whether we bypass these appeal courts. They'll not bypass the Supreme Court. Those appeal courts will hear this case and rule on these cases before the end of the year. What I'm leading to is this is going to the United States Supreme Court, and guess what? It's going in 2012. Just so happens to be an election year. Can you imagine? This is dynamite. This is this is really putting gasoline on the fire. And it will go to the Supreme Court, and I don't think anybody can tell you how the Supreme Court's going to rule, because we have 4 Democratic appointees, 5 Republican appointees, and ironies of ironies, the judge that will probably make the decision on whether this is constitutional or not has a name of Kennedy, Anthony Kennedy. It has put all the uncertainty into our administration, our management, our moving forward, our implementation. We will say it is the law of the land today. We will implement the law going forward. But there are lots of issues, and we would expend a lot of resources putting this thing together with the outside possibility that it may be ruled unconstitutional, and the whole thing would fall, and we'd start all over again. Last point here I would simply make is that it also includes the states. And the states, if there was anything that happened in that election that fall, last year, has to do with the fact that really there was a major change in the governorships out there. There's a major change in the state control legislatures. These are the guys who have to implement this. Why is this important? Because it's the state legislators that have to pass legislation to put in place the exchanges that go into effect in 2014 to make this thing work. And I don't know how these states are going to do this, given that they have a number of fiscal issues facing them right now. I'm not sure where Connecticut is today on this, but most states, quite frankly, have not done anything, and some states are saying they're not going to do anything. The only thing that there's only 2 states, your friends up the river here in Massachusetts and Utah, and California is moving toward it. And these exchanges are critical. because this is where these individuals will go. And quite frankly, I think the exchanges are a good idea. Make transparency, make it apparent to people what's available to them, and particularly for the small group and the individual, these make a lot of sense. And yet, because of the politics of this thing, going back, the politics of this today are playing a role, that you're finding that most of these red states are parties to the question about the constitutionality of this, the Florida case. This is unbelievably complex. Just the application of this to what you do on a day-to-day basis, but in terms of the overall system that we have to deal with, it is even more difficult legislatively, politically. I wish I could say I knew how it was going to turn out, but I guess I would say you're good students, keep aware, watch this. We're in for a real ride here through 2012 and beyond. So I've gone further than I should, but I wanted to give you that kind of background on why things are what they are.
That was really terrific, and information that we would not have known, but for the fact you're right inside that little world I used to call the lunar surface. Dave, do you want to make some comments now, and then Jim, and then we'll open it up for discussion?
Did you get the presentation I sent you?
I did. And can I be your Vanna White?
You absolutely can. You know what? I'm gonna stand in this corner so I can see the slides. So I'm gonna be honest. I saw William's slides and I said I better pull something together.
Yeah, that was absolutely.
And I grabbed her and better shot. That looks pretty impressive. That looks pretty impressive. But I did.
And wait, I did have to email Jim and say that they're having a slide war. Do you want to join in?
Let me tell you something. Mr. Collin is so much the senior seasoned executive in this marketplace and a mentor to all of you. He doesn't need to cry.
He doesn't.
Right? He does not.
There's all you need to know.
But don't think I was all that fancy. What's interesting is I was able to grab a couple of different presentations that I've had a chance to do over the past couple of years, quite frankly, that I think are very relevant today. And William was very generous in calling us the experts. In all my time here, in 6 years in the position that I'm in, I've never had an appreciation for the people who do the work in the state capitol as well as in Washington, as I did the past couple of years, trotting down to DC to meet with the Connecticut delegation many times as healthcare reform unfolded, and certainly there's a lot going on in Hartford. So these folks are doing some real heavy lifting in terms of helping us on the business side really understand how to navigate our way through the political system. Right when healthcare reform was sort of in that stage of, hey, let's take this to the public, I had an opportunity. I don't know if you remember the town hall meetings that were going on, and President Obama during one of the recesses said, okay, let's go out and let's bring this message to the marketplace. And in that picture, if you took a close look, Representative Larson is in the background from Connecticut, and Representative Larson and Senator Dodd actually were charged with having the first town hall meeting. Now, if you watch some of them on television towards the end, they got a little bit crazy, but we had actually the very first one here in Connecticut, and I had an opportunity to speak on that panel. And actually opened, at that point, my opening remarks were really pretty simple. It was really encouraging to see us talking about things like medical technology, medical records, evidence-based medicine, payment reform in the form of accountable care organizations, or all of these different things that start to talk about quality or delivering the right care at the right time in the right setting. All of that, if you were to rewind and listen to the healthcare reform discussion very early on, that's what we were talking about. And then what happened? Okay, well then, at some point it turned into insurance reform. And I want to just talk a little bit about the problem and a little bit about sort of how we got here with all the discussions that we're having right now. William was also generous. He talked about a special election. How many people know the special election that he was referring to? Anybody remember? A pretty famous Senate seat from Massachusetts. Okay, Senator Kennedy's seat. And what happened in that seat?
Scott Brown comes along, and Scott Brown throws healthcare reform into a tizzy. And shortly after that, and again, our company is equally committed to all of the components, many of the components of healthcare reform. We were actually very active in working with many of the initiatives that were proposed, but shortly after the Scott Brown election, we have a rate increase in California that really re-energizes the discussion about, hey, maybe what's wrong is insurance and insurance premiums, and look at this rate increase. So things slowed down a little bit with the Scott Brown election. They got re-energized around the discussion of premiums. And what was frustrating was there was not a lot of discussion about, okay, so if there's a premium increase, well, what the hell drives that? What's behind the premium increase? And that really is one of the things that we continue to try and keep front and center as we implement many of the components of healthcare reform that are insurance industry focused. And I think all of the companies are moving that agenda along very well. We have to keep the discussion focused at the same time on really what makes up a premium and what really is driving the problem. So I had a chance, so I tried this at the meeting. And this was a slide that I had a chance to speak at the New Haven Chamber a couple years ago. And it was a group of small businesses. There were 50 folks that were starting new businesses. And Tony CIGNA said, hey, could you come and talk to these folks? I wasn't sure what the heck I was going to say, so I did a little bit of research. And the National Federation of Independent Business, I think that's what NFIB is. You can probably still find this study out there. Every 4 years does a study to small businesses, and they say, you know, what are the biggest challenges that you have? Small businesses, for the purposes of this study, were defined as 500 or less employees, kind of the real lion's share of jobs in America. And this list changes over time, and it really is tied to the economy, whether, you know, capital is expensive, or access to credit, or taxes, or cost of fuel. If you look, and it gets done every 4 years, and if you looked over time, 2 through 10 change a bit. If you look at,
Next slide.
Yeah, next slide, please. Number 1, for 20 years running, this is 2008, for 20 years running, number 1, the cost of health insurance remains the top problem for small businesses in America, as it's been for 2 decades. This is right off of, you can look this study up. So I used this, and I said, well, this is sort of interesting. And I share with them, well, you know, I'm part of an insurance company, and you're starting a small business, and I'm your biggest damn problem. So this is sort of, I mean, that's a good reason that I'm here. Let's have some fun and talk about that. And I asked the question, and I'll ask you all this question. And this really ties to what I think is so important about how we continue to talk about what's necessary in healthcare reform. If I said to you, change one word in that sentence and replace it with something, I think it could dramatically change what we focus on in terms of the solutions that we're trying to find. What would that word be, and what could you replace it with? It's not a trick question. It's reform, right?
Healthcare, so health insurance.
Flip the slide. The cost of health care remains the top problem.
You're blaming it all on the providers?
I'm going to tell you why it's not.
I'm here to blame it on you two guys.
That's why you're in the anchor seat.
It's our, you know what?
I thought this out.
You know, the cost of health care is only partially driven by how much it costs. It's our insatiable, great appetite to consume health care. But if you really think about the cost of health insurance, well, then that could take you down a whole path in terms of the problems. If you just step back, change one word, that is not the word that's in the survey results, and it's not how people think of the problem. But if you think about just the cost of health care, and by cost, I don't mean the cost of necessarily a procedure at Gaylord. I mean just the total cost of how much we consume and how much we utilize. It really then starts to say, well, what are the things that we have to focus on? And we shifted away from that. We started there, but we shifted away from that. This slide, everybody's taken a different bite at this, but it's the slide of, you know, how miserable it's going to be for all of us a couple of years out. But what, you know, I think we said 17% GDP now, 18%, projections going as high as, you know, 20%. The bottom line is the healthcare, the cost of healthcare, or the amount of money that we're spending in healthcare continues to rise. So these are the reasons that, you know, it's not a case that someone decided healthcare was an issue that we should tackle. It's businesses, consumers, the amount of spending in healthcare was obviously continues to be at a pace that we have to talk about. Who pays the bills? One of the things that we talk about so much, and I'll get into this in a little while when we talk about government pay versus private pay, but if you just look at these three pieces of the pie, this is probably where the lion's share of our discussion is. Private health insurance, paying for a good portion of it, and then Medicare and Medicaid combined. And those numbers, some of these slides are old, those numbers have probably changed a little bit. So we've got a lion's share of the payment somewhere between private health insurance, part of the industry that I'm part of, and the government, between Medicare and Medicaid. Now here's the 85% dilemma. Okay, so here, before I put this slide up, and this comes from AHIP, I'm sure you've seen this slide, we've all used it, every one of us in the industry have used it as we've tried to position what are some of the things that we should focus on. And don't misunderstand anything I'm saying to suggest that we don't have our issues inside the insurance industry. But one of the things that we try to do is to say, look, let's put this problem in perspective. When you give when you spend $1 in premium, if we're going after health insurance costs and we want to lower the cost, we have to understand where the dollar is going. And in fact, as an industry, while we're all struggling with the 80% medical loss ratio or 85% depending on the group size, we're probably already operating as efficiently, if not more efficient. Now, it just varies based on what state or what segment when you break it all down. But if you roll everything up, you've probably got 85, 86% of the dollar that is paid in the premium that goes to pay for medical expenses. So when you talk about the administrative costs, that word profit, that's at the beginning, when you put that all together, it's 13, 14% of the dollar. And the point that we try to talk about there is if I ask the question, I bet you before you saw this slide, or now we're also educated with medical loss ratios, but there's a lot of, I tried to find the study, and I couldn't, but I'll give you the number. If you ask a group of folks, a couple say, how much of the insurance premium that you pay do you think goes to a profit of the health insurance company? And the numbers were 30, 40%. I mean, people really have perceptions that those numbers are really high. And that created then part of the problem. Okay, well, the problem we're trying to solve is that 30, 40% profit that the health insurance company is keeping. The reality is the numbers look like this. So, okay, so now we say, how do we start to then focus on the problem of healthcare, which presents itself in a health insurance premium many times. Start to focus on some of those problems. And there's a lot of legislation here that talks about insurance industry components that are moving the ball forward. But there's sort of the other side that you have to look at and say, okay, well, what's contributing to the rising cost of health insurance premiums? So, right, if we're going to try and control those costs, well, we have to have some discussion about what the heck is contributing to it. And again, some of this data is a little bit old, but the scale may have changed a little bit, but the issues are the same. If you just look at that 04 to 07, growth in premiums, I don't know, average those two out, 7, 8%. Just use that, maybe it's, whether it's 10%, the scale will be the same as you go down. There's nearly a third of that is driven by increased consumption, whether it's an aging population, lifestyle issues, which I'll talk about, new treatments, more intensive medication, drug therapies, diagnostic testing, defensive medicine, all of these things that go on that drive up that utilization, ultimately drive up the premium. Cost shifting is a big one, okay? Because if you're buying private health insurance, part of what's in your private health insurance is the cost of programs that are underfunded or those that are uninsured. What Mr. Cullen and I know is every time on averages somebody goes into the hospital with a private health insurance card, if the cost is $1, the person with the private health insurance card is paying $1.20 because underfunded programs are paying 70 or 80%. And then there's uninsured. So all of these things put pressure on the premium that we don't talk about a lot. And if in fact you're growing these programs, right now the state of Connecticut has issued a bid for Medicaid. Okay, our Medicaid programs, Husky for the children and the age-blind and disabled population, as well as the general Medicaid population. How many people do you think are in that? I guess. Let's say we got 3.2, 3.3 million people in the state, whatever the heck, somewhere around there. 600,000 people are covered by those programs. That's just Medicaid, okay? Medicare, put those two programs together, you've got nearly a third of the payment, and probably, if you look at those who are generating payment, take the uninsured out, over a third of the payment are coming from these programs. As they grow, if they're not funded properly, then again, increased pressure for the shift over to the private side. I don't have an opinion on that, I'm just giving you the algebra to say these are the things that we have to talk about when you want to talk about controlling the cost of premiums. Okay, so that's a big one in there. Waste in healthcare spending. So this is a case of where, and these studies, these numbers have been out there, whether it's defensive medicine, preventable hospital admissions, poorly managed diabetes, errors, unnecessary ER visits, all of these things that we're starting to talk about that I think both healthcare providers, insurers, and consumers agree to say, look, we've got to get some of this stuff under management because this is part of what drives the overall cost, which ultimately generates into a premium. Lifestyle-related issues. Okay, we all wonder, well, how do we control healthcare costs? And the last place we usually stop is what are the things that we could do ourselves. And these are some numbers: obesity, cardiovascular diabetes, asthma. These are things that, if managed properly, either we manage them ourselves or we have clinical programs to manage them, clearly can make an impact. And they're things that we know when they're managed well. But when they're not managed well, and decisions that we make in our lives not to do that, again, think about that dollar, 85% that's being used on healthcare, and how do we control it? Are we having discussions about some of these things to lower that utilization? This one I always thought was sort of interesting. If you look at the leading causes of death in the United States, and there they are, sort of, heart disease, cancer, stroke. It really is lifestyle dependent. So the data in the box says the underlying causes are things, again, that are driven by lifestyle decisions. And prior to these conditions causing death, there's a lot of health care that's associated with them. So it really then gets into, we're looking at the problems that we're trying to solve. Some of them are in that bill, but a lot of the issues that we talk about in terms of the 85% of the dollar on healthcare has to be addressed in these issues. I always find this one fascinating, that obesity, there's so much focus on childhood obesity from the First Lady on down to all the issues that we talk about. Well, I mean, this slide is, is fascinating. It shows the percentage of obese adults. And you can see, I think the 18 to 19% seems to be about the best practice in Colorado. Maybe it's the skiing there, but we know that the medical costs that are associated with that. And do we have an opportunity to go after these issues to focus on the healthcare spending? Fraud and abuse, I'm going to go through these quickly, but there's just so many things in the system, especially in some of the government programs, whether they're billing for services that are not rendered, upcoding, false diagnosis, all of the things that you hear about. You see on these news shows of addresses and people getting money just to have their insurance card, and then durable medical equipment devices billed all over the place. All of that stuff contributes to added cost that's in the system. So I keep going back to health insurance isn't important. It is the biggest problem. Take that next slide. Well, if I want to solve health insurance, I have to look at the cost of health care. If I want to talk about the cost of health care, then what are the different things that we have to talk about? So what the heck does all this mean? I'll throw this as my last slide. Flip one more. I think there's one more.
Okay.
Yeah. It really, and this is sort of that whole puzzle thing. It's not. And it's hard to call that thing one-dimensional because it is so big, but it's not one-dimensional. If I simplified that for a second and said one dimension is insurance market reform, and that's important. And we are, as an industry, moving that agenda forward. Quite frankly, many of the things that were adopted and that got a lot of early attention, the industry, quite frankly, had brought to the table. In our state, I mean, age 26, you may have heard about that. Many of you can stay on your parents' policy. Some of us may be over 26, but you can stay on the policy until 26. Connecticut already had that. Okay, there were some pre-existing condition issues. There are a lot of things that we already had. So insurance market reform is important, but you can't stop there. You have to talk about the cost of healthcare and a lot of the programs and issues that we talked about to really look at that, from lifestyle issues to transparency to understanding how we consume healthcare. We've got to talk about those pieces with the same energy that we've talked about some of the insurance market reforms. Quality and safety, so much discussion on that. How do we lower the cost of healthcare through better quality, better safety measures, and a whole host of strategies that are there. And then financing. What is the right way to finance care through the tax system, government versus private pay? Really looking at all of that stuff together, I think, is really what the future is. Now that we've got our teeth into this reform, there are components of those different dimensions that are in those bills. They're not quite as sensational to talk about at times as the MLR requirement or exchanges or Cadillac plans and all of these different things that came out that they generated a lot of interest. There is good material in there that talks about payment reform, that talks about for some of you who are in the medical profession, that talks about programs for accountable care organizations, or how do you just better coordinate care through primary care physicians that don't come out of the bill as much because they don't quite grab the headlines. But I think what's important for all of us to think about is it really is going to take a focus on a lot of different fronts. There's a lot of good thinkers that are working on this. And I always, when I'm followed by somebody as distinguished as a mentor of mine, I mean that sincerely, okay? This is somebody who's been a mentor of many people
This is called the setup.
in this market. When I say the cost of healthcare, don't translate that into what a doctor gets paid or what a hospital gets paid. I mean what's being spent, 85 cents. How much healthcare is being consumed? And quite frankly, unit cost management of that is just one small piece. If we consume 10 times what we need to, well, I mean, I could control that unit cost as much as I want, but the overconsumption is something that we have to think about. So I look forward to. I always love questions and stuff at the end, but I'm going to turn it over to the senior statesman in the room here.
Thanks, Dave. And
that's because, when he retires, all the phone calls about, hey, could you help with this committee, that committee? This one.
And Jim is, I thought out this sort of direction because Bill represented the macro and the hill and that terrific insider information in the transition into managed care. Dave is a leader in the managed care world in Connecticut. And Jim has lived the provider side, inside, outside, from an acute care and a rehab. So, Jim, if you give us, and with all due respect, Jim, you are a mentor to all of us. So, you should really feel good about that.
This is a setup. That's what happens when you're the oldest person here. Thank you. Obviously, I am really happy to be here because I do believe in sharing. And I say this to new employees at the hospital at orientation. Healthcare and education are two extremely laudable pursuits. So I commend all of you for committing your money, your time, your energy, your intellect, and most importantly, hopefully the rest of your life to helping people and to continuing to learn every day. Because I've been in this business for 40 years, and it really, you learn something new every day. Just listening to these great presentations. You constantly learn. So Angela asked me to talk about how healthcare reform might impact hospitals, particularly because in round numbers, when Dave was showing the allocation there, hospital payments roughly represent about 40% of the spending dollar in kind of round numbers. Angela also asked me to give my impressions on issues and trends in the healthcare environment, including hospital mergers, because we have had the announcement of a couple of them so far in the state of Connecticut. So in terms of health reform. And I just want to mention Medicare and Medicaid. Medicare, people over the age of 65, fastest growing percentage of the population, and will soon be the largest, if not already, the largest voting bloc in the United States. AARP is far more than a travel company and an insurance company. They are a very influential political force in Washington and have been, which I'm sure Bill would agree with. Medicaid, under the health reform law, I think it's 2014, the qualification for Medicaid is going to greatly expand, and many, many, many more people in this country are going to become eligible for Medicaid. And Medicaid is partially funded by the feds and partially funded by the states, which is why these governors are involved in these lawsuits, because they can't balance their budgets now, and Medicaid is going to grow. So the federal government in that bill was nice enough to deliver them another invoice that's going to start to come due in just a couple of years. So, and that's why Massachusetts, I guess, decided to do their all-payer system a few years ago, but they're wrestling with access issues, they're wrestling with how to pay for it, and they decided to cover everybody first and pay for it later, and that's exactly what this legislation does. It's not a zero-sum game. It didn't have to go through the whole pay-for issue that, federal budget folks in Congress work on. So I still think that's the biggest time bomb we have coming. People getting older, my generation, and more people going under Medicaid for the health bill, and quite frankly, how we're going to pay for it. Because I don't think we're going to change the lifestyle of people over the age of 65 anytime soon. So those that are diabetic, those that have heart conditions, I just had my knee replaced a year ago. I'm reading incredible data about how many knees are going to get replaced. And think about Medicare. It really is, this is what we'll cover, and this is how we'll pay people. They don't overtly ration care like are done in some other countries in the world. Covertly, there is a lot of rationing going on because they have to decide. But once they decide to cover something, as both these gentlemen know, the floodgates open up and there's another avenue of spending. The Medicare Part D for prescription plan about 5 years ago now, I guess,
2003,
added a bunch of dollars. But when you're in a political environment and you have a bunch of elderly citizens looking for this to be covered and that to be covered, and people on fixed incomes, and who many of the people on Social Security are, and then you have the poor people who don't always have a voice, like an AARP, to lobby for them. I just think we just have another train wreck headed our way. And how that might affect us in the short term, and these are my PowerPoints. Although, here's what this is my political message, because I was reading this last night while I was watching the Celtics game. And this is Health Leaders Magazine, and the cover article is Who's Accountable? So when Dave was talking about where's the accountability, and Bill was talking about it in terms of the Congress, that to me is the $64 question. Who is accountable? We as consumers have to be accountable. Politicians have to be accountable. Providers need to be accountable. Insurers. And sometimes we're all obviously out there looking to cover our own, kind of back ends, and it can get into some very heated debate. Many people believe nationalizing this is the best way. It's the only alternative. And they use the example of what the percentage of Medicare costs are to total Medicare spending, and then they throw that up at the insurance companies. And I think that's a fairly incorrect conclusion to draw, because there's no more spending than there isn't an insurance company in the United States that has a spending budget like Medicare does. So I would hope their administrative costs would be lower, because you're spreading it over so many millions of more people. But who's accountable? Really, you're all going to be involved in trying to figure this out. and it's going to be a big deal. So for hospitals, in the short term under health reform, what's on the table right now are reimbursement changes regarding value-based purchasing. No one likes the fee-for-service payment system that currently exists. No one, I say, from the policy side of this. Everyone wants, what's the value proposition? What am I getting in return for what I'm paying for? So currently I believe there's, and you probably have covered this in your classes, I think there's now 8 going to 12 hospital-acquired conditions. And they changed it when Don Berwick became the head of Medicare from infections to conditions, because falls became one of those hospital-acquired conditions, which is not an infection. And so it's HACs is now the buzzword. And there's a formula. If you don't make the threshold, they're going to take X dollars away. This is for Medicare patients. The second, which is coming up, I think this fall or January 1st, is the hospital readmission rate. Medicare estimates that they spend about 22% of their dollars on Medicare recipients that are readmitted to hospitals within 30 days of a discharge. There's a program which I would encourage you to read about called the Care Transition Programs out of, I think it's the University of Colorado or the University of Denver. There's a professor there that's been studying this for years, and there are basically 4 things that have a tremendous impact. One of which is patients, when they leave the hospital, do not feel they understood what their discharge instructions were. Nobody follows them significantly enough in that first 30 days is the second biggest reason. So in the legislation are all sorts of experiments for medical homes, which you've heard about. There's another one called the Continuing Care Hospital. There's money in there for that. And I think we've had our first physician, as a matter of fact, in the state of Connecticut within the last month or so who was declared, I guess, a medical home. Yeah. Because there's federal money out there for you to continue to advance, basically, I think, your IT investment and also having physician extenders. So those are 2 biggies that are right now in the face of principally the short-term acute care hospitals. So they are now starting to talk to other parts of the healthcare system. Because heretofore, institutionally, when you're discharged, you're done. You're gone. And it's been very fragmented, and coordination is what everybody wants. And obviously, managed care is a term that came up for me back in the 70s, when in 73, I think the HMO law was passed, health maintenance organizations. There's a lot of oxymorons here. It really isn't health care, it's sick care, we know that. Health maintenance organizations, the organization tries, but it's hard because we make individual choices. And a lot of insurance companies became labeled MCOs or managed care organizations, again, to try and manage the care. So short run, those are 2 big ones. In the medium to long term, there are 3 things that seem to be right here on the horizon for principally hospital providers. But this first 2 really do affect, I think, all parts of the continuum, especially the docs. Accountable care organizations, which to me is another phrase for a closed panel HMO. I remember seeing these back in the 70s, and under this law, I think you have to have 5,000 Medicare beneficiaries to qualify for money to become an accountable care organization. And the regs just came out within the last 2 weeks, as Bill said. Everybody's pouring through them right now. And I'm not sure, I think that was only a couple thousand pages. No, I'm kidding. 800 pages of the regs for ACO. It's significant, but I don't think it's as big as that. I think somebody told me it's like 600 or 800 pages.
Yeah, that's about right.
And it was greatly delayed. Everybody's been waiting for this for a while. Well, they're out, and there's only about a 60 or 90-day comment period on this. So they're going to close the door on comments pretty quickly. I think it's sometime in June. And I'll drop back later. I do believe this is what is starting to drive some of the provider consolidation. And doctors are now, we went through this probably about 15 years ago, running to the hospital saying, buy my practice. Align me with the hospital. Be my safety net. The other issue is, and I've asked Dave this question a few times, are the insurance companies going to try to become the drivers of the accountable? And in this article, it talks about Humana, which was in the provider business probably 25, 30 years ago, left it to become totally, and they have just purchased a company called Concentra, which is an occupational health organization. So they're now owned by Humana. So this article puts the, theorizes, will some of these big companies, a la the Anthems, the Aetnas, the CIGNAs, will they or will they not? I can't imagine they'd want to be in the provider business, but, necessity is the mother of all invention, so we'll see. But the second is bundling. There's been bundling experiments out there. They haven't been finalized yet, but I think they're due to come forward in either 12, 13, or 14 with bundling, and that means the payments. So now we're going to try to combine the providers. We'll get the payments lined up, so we're going to force this consolidation somehow. Third, which just came out, is tax-exempt status. Most of the hospitals in this country are not-for-profit. A lot of the difference between true cost and reimbursement is made up through philanthropy, interestingly enough. And the reason it is because individuals and foundations get a tax deduction for that. Well, a lot of people are saying if we're going to insure everybody and the government's going to be involved, we shouldn't need free care anymore. Why should hospitals have to be tax exempt? And for those of you in the compliance program, this may be your job security, because the IRS is going to start doing audits of the community benefit activities of hospitals in this country. And CMS just came out, or the IRS, I'm sorry, just came out with how many they're going to do over the next 3 years. And you certainly don't have to be a lawyer to do that review, like you have to be an attorney to do much of the other stuff in the compliance world. So there's going to be, I would think, a fair number of people being hired by the IRS, which the money is going to come from that bill for that. So from my perspective, those are 3 medium to long-term issues within this reform bill that are going to change the very landscape of how the providers are organized. Now, I can give you my semi-cynical perspective, and you can say that this is just the beginning step in a consolidation of the delivery system. As part of what Dave said for waste, there is a feeling that there's some oversupply. Are there too many beds? Is there duplication of technology? That gets talked about a lot, but there's never been a way to really force that consolidation. However, on the other side of the coin, and we see this in the state of Massachusetts with a tremendous provider organization called Partners Healthcare. They have gotten into issues from time to time with Blue Cross of Massachusetts over how much they want as an increase in their provider rates. Well, if you've got Mass General and Brigham and Women's and Newton Wellesley and this on the North Shore and out to the west and down to the south, and you've got a lot of coverage and you've got the best docs and the best hospitals, who now has the leverage? It makes it hard for Blue Cross of Massachusetts to go to their subscribers and say, and Dave knows this because he's in this movie here in Connecticut, I think with a few people.
A little while ago, I think I was in this movie.
With a few people. And so now you're trying to do the best job you can as an insurer for your subscribers and members and the people paying the bills. And now you've got a provider group that says, not so fast. I've got all the resources. So as we consolidate these providers, you could see some provider groups starting to look like the big insurance companies. And in a time of tremendous market change, I had the president of Aetna say this to me, the players with the biggest wallets usually survive. So in areas of tremendous need of dollars, those that have the capital will have the best chance of survival.
Is that what you meant by closed panel HMOs, ACOs we're going to look
Well, that was the closed panel HMO to me was to try and control risk, if you could. So, and then they got into, not taking the proper kind of, would you take all providers, any willing providers? Would you take any kind of subscriber. So they were really trying to control the care side, the closed panel HMOs. And people always have wanted choice in this country, and they just over the long term didn't survive. But as part of that, yeah, there was these exclusive contracts limiting hospitals and docs. It just wasn't favorable because in a lot of states where labor unions are the big purchasers for state workers, other folks, they want their members to have as much choice as possible. So economically, it didn't work out quite so well. But if we're going to consolidate providers, you know, in the short, midterm, one of the downsides could be some of these provider systems could be very powerful and going toe-to-toe with some of the big insurance companies. And not sure how that would work out. Other significant market impacts that I can see. I believe for providers, federal and state reimbursement has to go down. If we can't change people's behaviors, the next thing only thing you can do now is pay less for the services. If you can't make people demand less services, and it's a zero-sum game, you have to lower the price. If you can't lower volume, basic law of economics, you got to lower your costs somehow. And so the insurance company looks, and the government look at the providers, and they squeeze the providers. And given the rise in Medicare beneficiaries and the rise in Medicaid beneficiaries that are coming, I think it's going to be a very rocky time for the providers. And this consolidation perhaps is seen as one way to squeeze some of that excess out, that excess capacity. Provider consolidation is going to increase. So my last comments will be, in the state of Connecticut, we have seen something that I think started in Massachusetts, and I, working at St. Raphael's for all the years that I did, if you told me that those hospitals up in Boston, that Catholic system would flip to become for-profit, I would have looked at you and said, then you're crazy. It's never going to happen. And it obviously did. You know, the venture capital firm that bought Chrysler bought this Catholic hospital system in Massachusetts. And I would love if Angela could get the healthcare person from Cerberus to come down here and talk about what they are seeing in this whole thing. Because in Connecticut, St. Mary's just announced about 3 weeks ago that they are going to be 80% owned by a for-profit company out of Texas, LHP Hospital Group, and they will become a taxpayer in the city of Waterbury when this deal is finished and goes through all the regulatory requirements they have to. The Yale St. Raphael's, having worked at St. Raphael's for a lot of years and knowing what it was like to get up every day and have to compete and survive against Yale, I have very mixed feelings about that. You know, on one hand, in a lot of things in our life, we like choice. Do you want to be told you can only go to Best Buy? Or Walmart? Now, I'm picking on them, and I don't mean to, but they're big names. We'd like a little bit of choice. I don't think Bill or Dave would like to say, you got a choice. It's either CIGNA or Anthem. One of you has to say uncle at the end of the night and say goodbye and leave. So when you look at certain communities, and the argument in Waterbury is that they only need one hospital. That's been talked about for years. Well, what's going to happen now? Waterbury has hired investment bankers to go find them private capital. So, you know, that's going to play out. We shall see what happens. In New Haven, the sisters decided they wanted St. Raphael's to stay not for profit. But it took Yale to come to that table and make this happen. Why? Because they've got the money. And back to my comment, the biggest wallet will usually win. And healthcare, I mean, 60-70% of our dollar is people, wages and benefits. Not too many providers want to take cuts in pay. And the docs are facing that this December, and it will be probably Christmas before that gets voted on. They'll vote on that at the last possible minute on the SGR situation, and that goes back to 1997.
97.
It was part of the Deficit Reduction Act, was the sustainable growth rate, when Newt Gingrich and President Clinton made their deal. And it has carried forward with us since then. And it's been a hot political football every year since. And that's looming out there.
But it always gets under the rug because it never gets acted on.
They keep temporary, like we're doing with the government, you know, funded for a week, funded for a month, funded for 6 months. So are we going to see more provider on the hospital side? I think the answer is yes. The small community hospital, for Gaylord, we are a specialty provider. We are blessed with a sizable endowment fund, not as big as, you know, what I would like, obviously, but we are a specialty provider. So as long as we provide value in the continuum, I think we have a good chance that this 10-foot wave won't wash us over us, as long as we continue to show our value. I believe community health centers are going to be invaluable in this country, invaluable. And home care is invaluable. But everyone looks and says, what am I getting in return for that? What is the return versus the risk I'm taking and paying out? So I think it's going to be fun. It really is. So my last statement is, 3 last statements. If all healthcare, like politics, as Tip O'Neill said, another famous Massachusetts politician, is local, what does this mean for community hospitals trying to remain independent? Because a lot of community hospitals are seen the same way the church is and their school. They are the pillars of the community. People go to fundraisers for the hospital. They see their local hospital. They serve on the board. They love their local hospital. What is the future of these local hospitals in the wave of consolidation? Secondly, what happens to patient choice? That's a big ethical question for another day. And last but not least, where do the insurance companies fit? What is their role in all of this? Because that's part of what the political argument was. What's the value proposition for the insurance companies? And there are people in Washington who want to see the insurance companies go away. That's, I think, perhaps why it became insurance reform. Plus, I think it became that because they were easy targets. There's a lot fewer insurance companies than there are hospitals and doctors. And most of these people in Congress go to their hospital or see their doctor. I can tell you, hospitals lobby, the American Hospital Association lobbies as hard as the insurance industry does. And they have a number of, matter of fact, in my business, there's a for-profit hospital company in Louisiana. Bill Frist is on the board of that hospital. John Breaux is the former senator from Louisiana on the finance committee, is on the board of that hospital. That hospital company, they have got 8 former, either former administrators in the government or former senators on their board. You can bet when that company goes to Washington, they get listened to. And that's the American way. So it's going to be an incredibly fun ride. And I think I'm counting on you folks to do the right thing, because I'm going to be pretty soon a lot more of a consumer than a provider. And I hope you will all do the right thing. And one last political plug, I'm in favor of a Medicare means test. People who have plenty of retirement income can afford to pay towards that Medicare Part A premium, because you're paying the bill for us. You are paying the bill for us. And I think there's plenty of people my age and older who had done pretty well in their retirement, and I don't think they would have one problem. But this is where AARP comes in. You touch that, and that's almost like discussing Social Security. It's almost like the third rail. So I do commend Congressman Ryan for at least throwing the grenade out on the table. But having said that, I can also understand that there's plenty of other viewpoints, and that's why this is such a fun topic. Absolutely. And I don't think there's an answer. I think the first national health insurance legislation was proposed by Senator Thomas McIntyre from New Hampshire many, many, many years ago. It's been tried on many occasions, the issue of national health insurance. And it may be tried again. You know, we call it the single payer, public option. Those are the two phrases that you hear most of the time. So,
That's great, Jim. Thank you,
you know,
very much.
good luck. We're counting on you.
Thank you. Now, I would like to open up the floor. All of these gentlemen have carved this out on extremely busy days, and that to me is really what a true leader is to find this time to mentor and to give back and to share their expertise. I know Jim.
Yeah, I'm going to be scooting in about 10 minutes.
Okay, he
Get
needs
back.
to go meet
We have an
with his
employee
staff.
meeting at 9 o'clock.
Exactly.
Right.
So
9 and 10 o'clock.
you guys have been prepped a little bit. What questions? Please.
Besides even Medicare rates and different Medicare and Medicaid rates being lowered, I wasn't aware that the Medicaid pool was going to be opened up so much. I know in New Jersey, at least Medicaid rates were lowered, and like you said, it's so hard for hospitals and facilities to be able to balance that budget.
Mhm.
And now it's getting even harder because their costs are staying the same, but their reimbursement rates are getting lowered. How do you think facilities are going to be able to keep those profits and keep going? Gotta stay open, I guess. But I just want to
Well, that's why I think you are going to see more consolidation, because it is going to be harder for standalone hospitals to make it. I mean, that's just the reality. I can also argue, in at least in the Northeast, you don't have to typically drive 2 or 3 hours like you might in Montana or North Dakota or some other parts of the country to get to a hospital. We love our local hospital. And the easy answer is, do you need a 50-bed hospital? Do you need 2 hospitals in Waterbury, for example? That argument was made in Meriden many years ago. And I'll tell you, I thought people were going to almost kill each other one night. I was watching the debate go on. And we used to have health planning laws in this country. They were called health systems agencies. Because to try and really rationalize, and I'll tell you, it was unbelievable. It was like going to your town meeting.
Could I, because David raised this earlier, but Jim, could you respond? Would there not be further pressure to shift the cost back to the to us?
Oh, to the private insurer, absolutely. We do that now. I can give you another personal thought. I'd like to see this Medicare requires you to set prices at one level for all payers, even though they're not all paying for it. So what happens is, under Medicare, you have to still fill out a cost report, even though it isn't used in the reimbursement system, but it's the basis for it. It's called ratio of cost to charge, Medicare charges to total charges applied to cost, RCCAC methodology. So what we then do is we look at the shortfall from Medicare and Medicaid, we pass it on to the commercial insurance companies because we can. So that's part of the subsidy.
So we look like the bad guys, okay?
Absolutely. That cost shift has been going on for years, and it goes up and down, but the last number of years, it's obviously the gap's been widening.
I think one of the things that probably the market hasn't seen in a while is how rapidly those programs are expanding, and you don't even really see it, because the cost shift in the past, if there was gradual growth in those programs, the cost shift requirements were not as dramatic. But the numbers I shared in just what the Connecticut hospitals are dealing with, in the growth in Medicaid, I don't think people realize how big these programs are growing. Let me give you an example. There are people who work in this building who have their kids on Husky, because it may make sense, depending on your wages, and depending on how much your employer is charging for a contribution to family coverage, to move a child onto Husky. Every child can get it. It's a progressive scale with income, but over the past couple of years, there are employers who put that literature in their material. So what does that mean? Well, today somebody came in with a CIGNA card in their hand. Tomorrow that same child comes in with a Medicaid card in their hand. And the difference in reimbursement could go from 80 cents, from $1.20 to 70 cents on the dollar. And the ability to keep up with that cost shift now has gotten difficult. The other thing that's happened, and I'll share with you, the hospital St. Rachel's, that was one of the hospitals we had some fun with a couple years ago. and by fun I mean like CIGNA and other, like Blue Cross and others, we get to the point of where contracts expire and news gets in the newspaper about we don't have a deal. And what was unique about that one is we were all talking about the same problem. If you went back into the New Haven Register and you read comments from Chris O'Connor, the CEO, he talked about the fact that, in fact, we're making a profit on the managed care business, on the Anthem business, the CIGNA business, the Aetna business. We're just not making enough to keep up with how much we're losing on the government business. The problem is when you take on that argument, and the notion of self-insurance is a good one. It simply says, I'm your insurance company, but really you're going to pay me money to process your claims. At the end of the month, end of the week, or the end of the day, I'm going to come and stick my hand in your bank account, and I'm going to come and take the money out. And that typically has been when hospitals and insurers have these debates about rates, the public sees it as, it's the insurer not wanting to pay the hospital. Well, there is a more recent hospital payer negotiation that involved myself and this company with a big system, a good system in the state, but it got pretty public. And here's what happened differently. This is where I think the hospitals are starting to pay attention a little bit in terms of how you take that fight to the public. The argument was, well, Anthem's not paying us enough. We need more from them. Well, we, like CIGNA, have a lot of our business that's self-insured. At the end of the day, whatever rate we negotiate, we just go to the employer and we take the money out of their bank account. The fee that we charge to do that administration is fixed. It doesn't change. If I got to pay 20% more tomorrow on the claim, and the employer took a position. The employer took a public position. He said, hey, hang on a second. Those insurance companies, I'm not standing up for that, but understand this is my money dollar for dollar. So I think there's a couple of things that are going to be interesting as we move forward. I think the acceleration of those programs it's already outpacing what we thought. And the pressure to cost shift is not only, the ability to cost shift is not only going to be dampened because it's hard for us to pass it in a premium, it's the consumer starting to understand where that cost shift is really going to.
Yeah, and I don't think the government they will never be able to change that regulation, because the instant you do it, a balancing has to occur on the retail level, and Medicare and Medicaid's bill is going to go up, while the employer side will go down a little bit.
And to me, this leads to if we cannot control cost, if this legislation does not control cost, then there is a way to do it. The way to do it is the federal government will price set for all of us, and we will be back to what has been discussed. We'll just out of Washington, we'll tell you what the prices we're going to pay, and we will have national health insurance, and it will ration.
Yeah.
Bill, can
And
I
there's a lot of
just-
politicians who think that's a good, and other interest groups, I think that's a good thing.
Yeah, can I just ask you to just give a short synopsis on why it's so important for providers and those that are going to spend their days managing healthcare institutions to understand what goes on in the bill? Can you condense that? I say it all the time, but if they hear from somebody else, it'll make sense.
Well, I'm not sure. What 50% of health care in this country is paid for or comes out of government programs, Medicare, Medicaid. Half of all. That's supposed to drive. That's why we have the ACOs. That's supposed experimentation, various medical homes and things of that nature in the Medicare, Medicaid arena are supposed to drive the Anthems, the Blue Crosses, and the CIGNAs to change our policies. So everything that's coming out of Washington, given the size of it, given the size of the public expenditure in health care, what happens in Washington influences all the way down to the private sector. That's why it's so important to know what's happening in those legislations.
And it's so easy not to pay attention and just...
It's because it is complicated and it's messy.
Oh, it's extremely, and
But it's
you're not going
important.
to see an answer in 1 or 2 or 3 years.
By the way, before you leave, because I think Peter and somebody over here, you're going into long-term health care. We We haven't even
And leave a long-term
we haven't
care
even discussed here
administrator
this.
now. Right.
We haven't discussed here that issue. We all face. I mean, I've faced it recently with family. About 80% of that Medicare dollar is spent on 20% of the population.
Well,
Talk about the death panels. Talk about those. I mean, it's not just finances and it's not just legislation. We're talking about some extremely emotional, sensitive issues in terms of end-of-life discussions. And I don't think this country is ready to face up to that discussion right now.
Now, in Connecticut, nursing home care, I think the second biggest piece of Medicaid is payments for nursing home. You know, with the whole look back and, you know, people move the money or spend it down, and then it flips to become a Medicaid expenditure in the city. I think that may be one of the few Medicaid expenditures that are not based on income in the state of Connecticut. Medicare at least limits the number of days you can be in a nursing home. So they at least limit their exposure a little bit. But I don't know about other states, but in Connecticut, that is flipped eventually to Medicaid.
And we don't set our budget by watching what Medicaid dollars that we spend each year. We fix it, you know, not like 37 other states do based on what we spend.
Yeah.
Do you think that's a possibility, Medicare means, like, to determine, like, rationing?
I think it's a great idea, but that's why I'll never have it.
But
I mean, I work at the West End VA. I'm actually a needs test coordinator.
That's Larry Burnett, by the way.
Hi, Larry.
Was my previous president of the Student Club. I never let them go. They can, if they're still in the state, they're still here with us.
Yeah, so I'm the means test coordinator for the VA for veterans who get benefits, who doesn't, based on means. And they come in and they get mad with me because, I mean, they have, these are guys, it's based on, there's a whole lot of different criteria. It's based on service connections, based on PMT, physically and totally disabled, based on where you served, all this and any other. But it also looks at your income as well, and eligibility in the means test part. And these guys have Medicare A, have Medicare B, have Blue Cross Blue Shield, and when they don't get the VA care, they mad as anything because they want everything. And they keep, and I see it, they don't care about anybody else. It's only, what can I get, what can I get, what can I get? Sure. So I don't see it necessarily as the older people, you know, saying, oh, they're gonna be fine giving up that money. I have people that have, bringing in, as retired, $60,000, $80,000 a year, and they're mad if they have to pay copay.
Well, that's probably why it won't work, but it's just unreasonable not to do it.
Just be sure, and I'll be corrected here if I'm wrong on this, but we do have in this legislation, and we started it back 2 years ago, there is a Part B income adjustment to the Part B.
Yeah, I want Part A to be Medicare
means
testing.
All right, okay.
The Concord Coalition years ago was Warren Rudman out of New Hampshire and Paul Songus, who's deceased, from Massachusetts. When they both left office, they founded this Concord Coalition, which still exists, and they proposed that if your retirement income was $50,000 or greater, you would pay $500 a year towards Medicare Part A. For every $10,000 more in retirement income you had, that would go up $50 a year. So it's a tax. But it's a tax on people because otherwise you pay the Medicare tax in your paycheck.
By the way,
and that's going to go up tremendously. And guess what? The population's inverting here.
James, I just want to point out that all the proposals that are on the table in Washington right now, whether it's the president's or Paul Ryan's or any other proposal down there, right now today, it does not affect anybody that's 55 and over.
Right.
We got ours. It's you. And so it's amazing. It's amazing to me that the quote the AARPs of the world and others of the world are fighting this because hey, it doesn't affect them. It doesn't affect current retirees or those near retirement, and yet that's you would think that we've destroyed Medicare.
God bless the politicians because it's a tough go. On that note, I got to run.
Yeah, and I think what we'll do is, why don't we break the formal part? So let me say thank you to Bill. Thank you so much for bringing perspective here, and it's really valuable. I say it over and over again how important it is to understand what goes on in and around the Beltway, so thank you. Jim,
you.
this is not
Yeah.
the last we'll see of you.
No, I'm happy
Very
to do
much
it. No, it's fun. It's really,
appreciate
it's enjoyable.
Everything
I feel
that you
privileged
do.
to be here, I really do.
That's the way I feel every day I come and do this job. And Dave, thank you so much for being here. I know your day was crazy, and I very much appreciate, you've become a friend of this program too. So, once we get you, we never let you go. So I think that's a rock and roll song or something. So can we give these guys a warm...
I want you to sign something.